Today, I'm excited to be joined by Dr. Catherine Frenette, who is a member of the American Liver Foundation's National Medical Advisory Committee. She's agreed to answer some questions for us about liver cancer surveillance. But first, let me tell you a little bit about her. Dr. Frenette is the medical director of liver transplant at the Scripps Center for Organ Transplant at Scripps Green Hospital in La Jolla, California. She's also the medical director of the Liver and Hepatocellular Cancer Program at the Scripps MD Anderson Cancer Center. Dr. Frenette underwent medical training at Rush Medical College in Chicago, Illinois. She then completed internal medicine training at Scripps Mercy Hospital in San Diego, California, and subsequently underwent training in gastroenterology with a focus on transplant hepatology at Scripps Clinic in La Jolla, California. Dr. Frenette understands that liver disease is a complex process that requires a team approach to diagnosis and treatment, and she sees each patient as a partner in his or her own care, which I must say is laudable. Dr. Frenette has special clinical interest and expertise in liver transplantation to treat cirrhosis, liver cancer, autoimmune hepatitis, viral hepatitis, acute liver failure, and end-stage liver disease. In her practice, Dr. Frenette provides comprehensive evaluation and treatment for liver problems that include primary biliary cholangitis, hepatocellular carcinoma, primary sclerosing cholangitis, hemochromatosis, Wilson's disease, fatty liver disease, alcoholic liver disease, and acute liver failure. That's a lot of things. With a combination of compassionate care, leading-edge expertise, and widely recognized medical leadership, Dr. Frenette leads the Scripps liver transplant team in their efforts to improve outcomes and save lives. Thank you so much for agreeing to meet with us today about the importance of liver cancer surveillance. Would you start by telling us why liver cancer surveillance is so important?
Absolutely. And Susan, I just want to congratulate you on reaching the 5-year mark. It's really fantastic, and I'm very, very happy for you.
Thank you. It has been life-changing.
So, and today we're really going to do 8 questions about liver cancer surveillance, and I'm happy to hear your input from the patient side as well, because I think that's really important. You know, I can think about all the medical piece, but I think, you know, it's different when it's from the patient side.
Absolutely.
So you should be able to see my slides now, and I'll just go ahead and start with the first question that you had brought up, which is, why is liver cancer surveillance so important? And really, I think the first thing that I wanted to talk about is really some vocabulary, I would say, because we hear about liver cancer screening and we hear about liver cancer surveillance. So when we talk about screening and surveillance, they're really 2 different things. So screening is really applying a diagnostic test, which could be blood tests or imaging or procedures like a colonoscopy in someone who is healthy. So when someone goes and gets their colonoscopy when they turn 50, that's a screening test. Surveillance is really about a patient population that's at risk. So when we talk about liver cancer screening, we really should be talking about liver cancer surveillance, because we're doing this in patients that are at risk. For instance, patients who have hepatitis C or had hepatitis C and now cured, but still have scar tissue in their liver, or alcoholic liver disease, or, you know, a whole slew of liver problems that we'll talk more about. And this is a serial application of testing, whether it's blood tests or imagings or procedures, in those patients who are at risk. So really, we're talking about liver cancer surveillance today.
Mm-hmm.
So why is it? Yeah. So why is it so important? Well, because it saves lives. Okay, so I'm showing you now some data from Japan, and the reason that I'm choosing this data from Japan is really because the Japanese are amazing at actually getting people under a surveillance program and keeping them under a surveillance program. In the United States and in many countries, it's very difficult to keep people in a surveillance program because we all get busy and 6 months goes by really fast. And, you know, your doctor, Susan, was great at keeping you in the surveillance program. Unfortunately, sometimes that doesn't always happen. And what we see is actually, you know, less than about 30 to 40% of patients in the U.S. that should be in a surveillance program for liver cancer, they don't actually get their regular surveillance. So it's hard to show this data in a U.S. population. The Japanese have really put in this nationwide surveillance program for people with underlying liver disease. Are you able to see my arrow, Susan,
Yes.
on the slide? Excellent.
Yes,
so before 1980, there was not a surveillance program in Japan. And what you can see, that's this dark blue line right here. You can see that survival in liver cancer patients was really pretty dismal. Median survival was about 3 months, and that was when about 15% of people had screening. If you then go, let's just hop right to the current era. You know, this is 2001 to 2013. 75% of people actually stayed in their surveillance program and received their screening. And look at this survival. Survival went from 3 months to 52 months. And that's this orange line right here, okay? So this is really very telling that liver cancer surveillance saves lives, okay?
Mm-hmm.
Now, the question is, why does it save lives? Well, it saves lives because it's detected early. So you may have seen when you develop liver cancer, and some people also see this, when someone develops liver cancer, oftentimes it causes no symptoms at all whatsoever. It's just picked up on an ultrasound or an imaging test or something like that. And that's when it's detected early. If it's detected early, we can cure people. We can send them through a transplant and 6 years later be having them do a liver cancer webinar to educate other patients like Susan. But if we wait and don't do screening and don't do surveillance, and we diagnose the liver cancer when it's later, it's actually very difficult to do adequate treatment. So we know that when patients are in really robust surveillance programs, we find the cancer early and we're able to offer them curative therapies. And that's really, really critical.
Mm-hmm.
What I tell my patients is, I want to find your liver cancer when it's the size of a golf ball. Your liver is the size of a football, and you can hide a lot of golf balls inside a football with not having any signs at all. No symptoms, no pain, no change in labs, no change in liver function. And so that's why we really have to do the imaging to be able to actually find this early.
Yeah, I did have, when my liver cancer was found, I was able to have a microablation, which pretty much got rid of it. So the surveillance after that was just to make sure that it did not recur, which was very important. And it was very evident to me that it was important to continue on with that surveillance.
Absolutely. Absolutely. So that's really the benefit that we see. So,
yes, how often do cirrhosis patients get liver cancer? How frequently does that occur?
yeah, and that I think is a really critical question when we're thinking about, is this surveillance really worth it? We know patients come and say, well, why am I getting this? What is my risk of getting liver cancer? Okay. So first, let's talk about liver risk factors, which is important. What we see in general is that when patients have cirrhosis, we see about 2 to 5% per year, okay? Most liver cancer develops in a liver that has cirrhosis, okay? So that cirrhosis can be from anything. It can be from hepatitis C. It can be from non-alcoholic fatty liver disease. It can be from alcoholic liver disease, autoimmune problems, inherited problems like hemochromatosis. But that cirrhosis, that scar tissue happens with chronic damage from the liver, okay? Hepatitis B is a little bit of a special case I'll get to in a minute. But when we think about cirrhosis causing liver cancer, the question is, well, why does it cause liver cancer? Okay, so what happens over years from whatever is going on in the liver, whether it's hep C or autoimmune problems or alcohol or whatever, that chronic damage over years develops scar tissue, and the chronic damage over years actually damages the cells in the liver that then can turn into cancer cells. So I think of it like skin cancer. So Susan, what causes skin cancer?
The sun.
The sun, chronic sun damage, okay? So just like chronic sun damage causes skin cancer, chronic liver damage causes liver cancer. Chronic lung damage from smoking causes lung cancer. So anywhere in our bodies that we have chronic damage happening, that is a risk for cancer, okay? So that's why cirrhosis is such a risk factor for cancer. Now, hepatitis B is a little bit of a special virus, and the reason that this is a special virus is because hepatitis B can cause cirrhosis and then liver cancer. But hepatitis B can also cause liver cancer without cirrhosis. So it's one of the very few cases that we actually see liver cancer developing without underlying cirrhosis. The reason that this happens is that hepatitis B is a really sneaky virus. It actually goes into the nucleus, the brain of the liver cell, and it hides in the liver cell brain. And what it does is it actually integrates itself into the DNA of the liver cell. So now it's hiding in the cell's DNA. And when it does that integration, it actually, if it goes in the wrong place, it can turn on what we call an oncogene, okay? So if you know what an oncologist is a cancer doctor. So the word onco is the root that means cancer. So all of our cells have these things called oncogenes in them, which are cancer-causing genes. I don't know why they're there, but they're there. And if they get turned on, that causes cancer. Hepatitis B can actually turn them on just by getting into the wrong place in the cell without having that chronic damage. Aflatoxin, luckily, we don't see very much anymore, but this is a problem we used to see a lot in the Asian countries because the aflatoxin is a mold that was in some food. And if you got exposed to aflatoxin via foods that were stored improperly and had this mold growing, it could also cause liver cancer. Luckily, this is almost gone. We don't have to worry too much about aflatoxin now because of the way that foods are stored. So that's who gets it. So what is the exact risk? Well, of course, it's difficult to say exactly, but what we see is that, like, for instance, hepatitis B patients with cirrhosis, they get it about 3 to 8% per year, okay? Hepatitis C cirrhosis, 3 to 5% per year. Hepatitis C with bridging fibrosis or stage 3 scar tissue, they actually have a higher rate of liver cancer too, 1.5% per year. So in general, most cirrhosis we think is somewhere around 3 to 5% per year. Patients with hepatitis B who've had it for many years, like Asian men who got it when they were born or when they were infants, it's about 0.5% per year. Over the age of 40, Asian women over the age of 50, it's also about 0.5% per year. So that's about the percentages that we know. Now, the other thing to realize is that this is a cumulative risk, okay? So every year that you have cirrhosis, you have a 3% chance. So there was actually a really interesting study that was done out of Michigan, where they took patients who had chronic hepatitis C cirrhosis. This is in the years before we were able to cure them so easily. And they watched them because they couldn't get cured. They watched them for about 20 years. In that 20 years, almost a third of those patients got liver cancer because they had it long enough. So this is a cumulative risk, okay? Now, what does that mean in the United States? Well, we're actually seeing right now that liver cancer is actually the leading cause of cancer death worldwide, over 700,000 cases. In the U.S., it's estimated that in 2020, we're going to have over 42,000 new cases and over 30,000 deaths. Okay,
Wow.
so it's really a huge problem that we're seeing. What's interesting and is bothersome and scary is that in the last 25 years, cancer rates overall have dropped about 27%. Liver cancer is actually the fastest rising cancer in the U.S. by both how often it happens and how much people die from it. So
Wow.
it's one of these cancers that are really increasing. And right now, the 5-year survival rate's about 20%. And that's, of course, much, much better if you find it early. And this slide just shows you graphically what that increase looks like, okay? So you'll see 1975 up to 2005. Overall, our cancer rates have tripled in the last 30 years for liver cancer, okay? And then we're also seeing that liver cancer death rates have also gone up in the same way. So unfortunately, we are seeing this. Part of this is because of hepatitis C. We are actually just barely starting to see the hepatitis C rates go down because the direct-acting antivirals were able to cure people. We are unfortunately seeing a ton of liver cancer skyrocketing because of non-alcoholic fatty liver and still because of alcoholic liver disease too. So this is projected to continue to increase at least another 10 to 20 years.
Wow.
Yeah. So, oops, sorry.
Yeah. So what can I do to make sure I'm safe when I visit the hospital for liver cancer surveillance now during the pandemic?
So I think this is a really good question. And part of the scariness that we're seeing with the pandemic is that patients are scared to come to the hospital to get their care. So we're actually seeing quite a bit of care is delayed. For instance, you know, we'd have people that would come in with abdominal pain because they had acute appendicitis. Now we're seeing more people present where it's very late and their appendix has burst because they didn't want to come in because they were worried about the pandemic. I think what I would say that in terms of what to do to make sure you're safe, number one, wear a mask. No question. Most important, wear that mask, okay? And it's got to be covering both the nose and the mouth.
Mm-hmm.
I see some people where it just covers the mouth, and obviously that isn't great because you still have your nose. It can be difficult to breathe, and it's a little uncomfortable, but it is so, so important, and masks definitely work. Number two, wash your hands or use hand sanitizer like crazy. I've got, you know, my little hand sanitizer that's my travel buddy, and he sticks on. And we always just use tons of hand sanitizer. Number three, keep that distance. You know, when I'm around the hospital or when I'm waiting for my own tests, I always make sure to stay at least 6 feet away from people. If I have somebody that comes in and they sit down closer to me than 6 feet, I get up and move. And it might seem rude, but that's what I do because I'm worried about both keeping myself safe as well as keeping others safe. Most hospitals have really put in a lot of things to try to keep people safe, including, you know, making sure there's lots of hand sanitizer and sanitizing between patients and making sure that there's enough distance in the waiting room. Some places are having patients wait in their car, but when they check in and then they call them and say, okay, we're ready for you, now come in. And you can, if you're worried, you can call your own hospital and find out what their protocols are.
Mm-hmm.
Susan, what are you doing to keep yourself safe?
All of the things that you just mentioned. I have actually had to go into a hospital recently and was asked to change the mask I arrived with into a new mask. So there was screening right at the door. They asked questions of whether I had been exposed knowingly to anybody who might have had a cold or any other symptoms. And then, you know, went on to my appointment and was careful to make sure I kept that distance. I also have been known to ask people to, you know, I'm going to step away from you. Could you step away from me as well? So I'm
Yeah,
not shy about making sure that, you know, people are observing what the guidelines are recommending.
absolutely. Very true. Very true. And I think that all, it makes a lot of sense. Um, the other thing that we're worried about is this question.
Yeah, deferring care. Yeah.
So the concern that we have, and I mentioned a little bit of deferring care, like our patients that used to come in with abdominal pain with appendicitis, and now they're coming in with a burst appendix because they deferred coming in. We're seeing the similar kind of deferred care in cirrhosis that can have consequences. I worry about patients that canceled their liver cancer surveillance and didn't go get their labs or their imaging, and you know, what if something's growing in there and now we're going to find it when it's more advanced? Or you know, that I'm worried about patients that didn't get their labs, and they, you know, now they're coming in and they've got terrible infections because they didn't get their medicines because they were worried about going into the pharmacy, or, you know, people who needed endoscopies to look at their varices, and now they're coming in with awful variceal bleeds. So I think there are definitely consequences, and I honestly think that we'll probably see a rise in liver cancer in the next 6 to 12 months because patients had deferred that screening test, and now we're going to be finding them more advanced. So that is concerning, and I think one of the things is something we just have to remember is that we still have to do our normal health care. In the middle of this pandemic, we still have to take care of other medical problems too.
And from what I've read, it seems that most hospitals have tried to isolate COVID-19 patients to certain parts of the hospital. So in my view, the hospital may be the most safe place to go, more so than a grocery store. So,
at least yeah, you're right. At least in the hospital, patients are getting screened for symptoms and they have to wear a mask. You're right. And a lot of places are doing, you know, sort of COVID areas and non-COVID areas. I know in our hospital, we have several imaging and lab places that are not directly in the main hospital, and we have some of those that are designated as non-COVID imaging places. So they still do, you know, symptom screening, and everyone has to wear a mask, and they're still sanitizing everything. But if there's anybody that has any respiratory symptoms at all, they don't come in there for their imaging test, for their chest x-ray or whatever they need. They have to go to the main hospital. So I think is really, really important. And I think a lot of healthcare systems are really working to make sure that patients are still getting the care that they need.
Yeah, and that's where the expertise exists for infection control. So
Exactly.
safe.
Exactly. Yep. So
Yeah. So how often should imaging be done? I guess that depends on the stage of one's risk.
yeah, well, sort of. I wanted to talk both about imaging as well as about blood tests. So we know that there are blood tests for liver cancer, and there's also imaging tests for liver cancer. The blood tests there's a little bit of debate on whether they're beneficial or not. I strongly believe in the blood tests. The problem with alpha-fetoprotein alone is that we know that only about half of liver cancers actually release alpha-fetoprotein. So an elevated alpha-fetoprotein helps you, but a normal alpha-fetoprotein doesn't necessarily help you. A normal AFP does not mean that liver cancer isn't there, okay? Sometimes too, AFP can be a little bit tricky because other things can make it be elevated. For instance, someone who has inflammation in their liver, their AFP is going to be elevated just because of the inflammation and the liver cell turnover. So AFP is just a marker of liver cells growing, okay? So like if you have half your liver taken out for a cancer, that first month or so afterwards, your AFP is going to be really high because your liver's growing to replace what we took out. Or if you have chronic hepatitis C that isn't cured yet, your AFP may be elevated because your liver has this inflammation and it's regenerating constantly. The AFP-L3 is an interesting blood test that can be helpful, especially in patients that we can't tell, is the AFP elevated because of a tumor or is it elevated because of inflammation. So AFP-L3 is a little bit more cancer specific. It's a subtype of AFP, and it's a separate order. It's a separate blood test. But if I have someone whose AFP is 30, for instance, a normal AFP goes up to around 10. If it's 30 and I only have one level and I can't tell, like, is this 30 going up or 30 being stable, the AFP-L3 can be helpful. If it's a high percentage, then I'm more worried that there's cancer in there and I need to do more imaging. The DCP, or des-gamma carboxyprothrombin, this is another, I know, it's a mouthful, yeah, but DCP, it's another blood test for liver cancer. Some liver cancers release DCP, but do not release AFP. So it's just another blood test that can be useful to say, is there something in there? And then imaging tests, we talked about, or you mentioned, ultrasounds, CAT scans, and MRIs. So these are the three main imaging tests that we do for the liver. You'll notice for liver cancer, PET scans are not on there. And PET scan is not a scan that we very often do for liver cancer because it's not a great test for liver cancer. A lot of them can be negative. But the critical thing to know with CTs or MRIs, if you're going to use those to look for liver cancer, they have to have contrast and they have to be what we call multi-phase. So it has to be timed in a really particular way. So if you were to go into the emergency room with abdominal pain and they did a CAT scan on you, that's not going to necessarily, or usually not, be a multi-phase with contrast. So that's not going to tell you, is there something hiding in your liver? And you can't count that as your imaging for liver cancer, okay? So that's a really important thing to realize.
So the multi-phase is the reason you do the in and out and the holding your breath and not holding your breath.
Exactly, that's why. Okay. Now there's a whole bunch of different guidelines for liver cancer surveillance, and people are generally on the same page, not 100%, but generally people, all the different associations and networks recommend imaging every 6 months, okay? And then usually with alpha-fetoprotein, the Japanese actually recommend also doing the extra tumor markers, the AFP-L3 and the DCP. We do know that if patients are waiting a transplant, we should do a CAT scan or an MRI, not just an ultrasound. I really do find, the American guidelines say ultrasound with or without alpha-fetoprotein, and they really leave it up to the doctor's choice. I really find that AFP is very, very helpful, and this is why. So when we look at how sensitive is an ultrasound for liver cancer, so what sensitivity means is how often when someone has a liver cancer is the ultrasound going to find it. So this was a study where they actually pooled a whole bunch of different studies together, and they said, well, how often did they actually find early stage liver cancer? And overall, an ultrasound by itself finds 47%. So not great, right?
Right.
Better than nothing, but it's not great. If you add alpha-fetoprotein, it goes up to 63%. So still not perfect, not great, but definitely better. So that's really why I like it a lot. So I do both of those tests every 6 months. The other interesting thing that is coming out is this, what we call biomarker panel. Okay, so this is called the GALAD score, G-A-L-A-D. And this uses those extra biomarkers that we talked about, the AFP-L3, AFP, DCP. And it's a calculation. You can literally go onto Google and type in GALAD score, and you can calculate your own GALAD score. And this will actually tell you what is the chance that an early HCC is in this patient's liver, okay? And you can see when you're looking at all these different cohorts, and whenever we do a test like this, we want to look at it in a bunch of different patient populations to say, well, what is the actual, is it good in every patient, or is it only good in men, or is it only good in Asian patients, or whatever. But in general, the sensitivity or the amount of liver cancers that are picked up using the Galid score is a little bit better than just the ultrasound and AFP. So between 60 and 90%. Okay.
Why is there such variation there?
Probably, so part of it is it's looking at the amount, like how early is the liver cancer picked up, okay? Is it small cancers? Is it all cancers? It's different patients, it's different patient populations. So there's a UK cohort, there's a Japanese cohort, there's a German cohort. So these are all different types of patients, all different types of liver diseases, okay? So Japanese might have more hepatitis C, whereas Germans might have more alcoholic liver disease. And this is part of the research to figure out, you know, is this actually good for all patients? And it is, you know, that, and we always see a range like this, okay? But yeah, so that's really how it can be useful. This is pretty darn new. And so it really isn't picked up in a lot of the guidelines yet. There is a comment in the latest guidelines that the Galid score may be of use, but I think generally it takes a lot of studies and a lot of real world data also to actually get something incorporated into guidelines. But this is something that can be useful in some patients.
I see. Thank you.
Yeah.
Okay, yeah, as far as the comfort or discomfort with getting imaging done today, we talked a little bit about that, but have you had experience with your own patients?
Yeah, I have. I've had patients even that we know have liver cancer that really are uncomfortable about going to get their imaging test done. And we always have a conversation about it. We have a conversation about what they can do to protect themselves, what they can do to make sure that they're going to be safe. And we also talk about the importance of it, you know, and sometimes they say, well, let me get a blood test first and then let me think about it. But most of the time after further discussion, we are able to say, yeah, this is important. We really do need to get this done. And we can get it done. But it is very, very common that people are uncomfortable. Honestly, I'd rather they be uncomfortable to leave their house than be laissez-faire about it and be going all over the place. So I'm okay with this as long as we actually can talk through it and get it done. And I'd rather people be careful and stay home as much as possible, especially when they have liver disease.
Yeah, I have received several types of correspondence from my transplant center because, of course, the information that's available to the general public is if you have any kind of immune compromising situation, which we all do, you know, you are at the highest possible risk. So that makes it very frightening to enter a situation where you know you might be exposed. So I just make a point of checking in with my own physician to make sure, does this apply to me? Should I be coming? And that's kind of, I guess, the best way to make sure that you're doing the right thing.
Absolutely right. That's exactly what should happen. Yep.
Yeah, and what is your awareness about how protocols have changed at the different hospitals in terms of liver cancer surveillance during COVID?
So there's been a lot of discussion about this, and there's been a lot of the different foundations and educational places like the American Association for the Study of Liver Disease, the European Association. We've had a lot of webinars, we've had a lot of meetings about what is the right thing for people, because we do want to protect them from COVID-19, but we also don't want to put them at risk for bad outcomes from their liver. So after a lot of discussion, there's actually just a very recent study review article that came out. And this is specifically talking about people who've already had liver cancer, and now we're watching them to see if it recurred. So generally what is recommended if you have a resection or an ablation like you had, or a chemoembolization or radiation, we do scans about every 3 months under normal conditions. That's sort of our standard. We do a scan about a month after and then every 3 months. Now what they're recommending is that you can delay that a little bit, maybe go out to 4 months instead of 3 months. Maybe instead of doing it a month after your taste, do it 8 weeks after your taste. So really sort of extend in between. We do know that for liver transplant patients, UNOS, the United Network for Organ Sharing, does require imaging of the abdomen and an alpha-fetoprotein at least every 3 months to maintain your list on the transplant list. But if there's patients that we are not very worried about the cancer growing, the consideration in this paper was maybe extend that to every 4 to 5 months. I would say personally, I still have anxiety about patients that I'm waiting for a transplant to not keep their points going, because with UNOS, if you don't have that imaging every 3 months, you're going to lose your points, and then you have to reapply and get them back. So that's a conversation. Yeah. So, and that's a conversation that every person has to have with their doctor about what's right for them.
Right.
For people who are on systemic therapy, we have all these new systemic therapies for liver cancer now, a ton of them. And what the recommendation is that it really, in your patients that don't have an elevated alpha-fetoprotein, then we have to do imaging. And again, maybe instead of doing it every 2 or 3 months, maybe we do it every 4 months or 5 months, depending on how people are tolerating the treatment. If you have an elevated alpha-fetoprotein at baseline when you do your treatment, you actually can then use that alpha-fetoprotein to help decide when is the right time to scan. So for instance, you start your AFP, say your AFP is 100 when you start. 6 to 8 weeks later, you get labs. If it's stable or going down, then don't image. Just keep treating, okay? Don't even risk going in for the imaging, because we're seeing that alpha-fetoprotein improvement. If it's going up, then you want to think about imaging, okay? Because then you want to see, is it actually progressing? Because sometimes we see it sort of go up and then come back down. And you really need that imaging to make a decision about whether changing therapy is the right thing.
Right.
So,
awesome.
So that's the recommendations right now.
Okay, and then can you just talk a little bit about how liver cancer surveillance works post-transplant, and how, when, how, and why it's done?
Yeah, and you have personal experience with this, I know. So when someone has a liver transplant, hopefully that's a curative surgery for that patient. But we do know that there is a risk of liver cancer coming back after transplant. It's somewhere on the order of 5 to 15%, depending on the patient and some characteristics. And we also know that if we find it early and get them started on treatment early, we're going to have a better outcome than finding it late, especially with all these new systemic therapies that we have coming out. So after transplant, we definitely want to image someone to see, is their cancer coming back, so that we can address it and find it, right? There's really no clear guidelines from any one place of this is the best way to do it. So a little bit of it is every hospital sort of develops their own protocol and follows their own protocol as we're trying to gather data on this. So your transplant center may have a different protocol than my transplant center. But what I really like is the retreat score. So the retreat score is a score that was published from Neil Mehta at UCSF. And what it does is it actually looks at characteristics of the patient themselves and their cancer to give us what the risk is of recurrence. So you look at the alpha-fetoprotein at the time of transplant, what the level was. Then you look on the explant, the old liver that came out, was there evidence of microscopic vascular invasion, which we know increases the risk. So the higher your AFP is, the higher the chance the cancer is going to come back. When there's microvascular invasion, that is a higher chance. And then it also looks at the amount of tumor in your liver that it came out on what we call the explant. That's the old crummy liver that we're throwing in the garbage, okay? So you look at, is there, you know, how big is the largest viable tumor, the one that's still alive? If it's dead, it doesn't count. And how many viable lesions do you have? Is it, you know, the largest one is 2 centimeters and you have 2 lesions, that's a score of 4. So 1 to 4.9, that gives you 1 point. So then you add up the number of points, which then gives you a surveillance regimen. Okay, so really this is saying, what is this person's risk of cancer coming back? And based on that risk, how often are we going to scan them? Okay, so someone who is low risk, they would get a scan every 6 months for 2 years, because most people who recur in the first 2 years. Medium risk every 6 months for 5 years. High risk every 3 months for 2 years, and then every 6 months until year 5. And that's including imaging of your abdomen, again, that multi-phase imaging of your abdomen, as well as a chest CT and a serum alpha-fetoprotein. Okay, the places that liver cancer likes to come back, number one place it likes to come back is in the new liver. Okay, the way that I think about it is, when we think that when liver cancer comes back, sometimes it's actually tumor cells that are circulating in the blood. And the way I think about it is, these cells are sort of running around in the blood. They land in the new liver and they say, oh, this feels like home. I'm going to set up shop. And they set up shop, and now you have cancer in your new liver. So that's number one. Number 2 place it likes to come back is in the lungs. And number 3 is in the bones. And if it's coming back in the bones, usually it causes a high alkaline phosphatase, and then you can chase that down and find it that way.
Oh.
So that's what the retreat score is. Now, there have been some changes that have been made, again, changes in surveillance because of COVID. And so what the recommendations is that you then go, instead of every 6 months, you go 6 to 8 months. Okay. And then instead of every 3 months, you go 3 to 6 months. So you just extend it a little bit. Okay. So that is really the surveillance recommendations during COVID. But generally, we do end up basically saying, let's go ahead and scan this person for up to 5 years. Once you hit the 5-year mark, you get to have that cure celebration. And then we just monitor labs from there.
And it was a celebration, I must say.
Yes, absolutely.
Okay, well, thank you so much, Dr. Frenette. That was very insightful. You enlightened me on some things. I thought I was pretty well informed, but I learned some new things from you today. I really appreciate that.
My pleasure.
Anybody else who's been listening, if you'd like more information, you can certainly find that at liverfoundation.org, or anytime call the liver hotline, which is 1-800-GO-LIVER. Hi, my name is Susan Ventura. I've had a long history of liver disease, beginning with my diagnosis of hepatitis C in 1991. It took 21 years, but I finally cleared the virus after 3 separate courses of treatment. Unfortunately, by then I had developed cirrhosis and was diagnosed with liver cancer just a few months later. My hepatologist at the time told me that the cancer diagnosis was actually good news, because it would move me up on the list for a liver transplant, something I'd needed since my liver began to fail 10 years earlier. It didn't really seem like good news at the time, honestly, but it did turn out that she was right. I was lucky enough to receive the transplant that saved my life, especially the quality of my life, just 14 months later. Surveillance was an important part of my healthcare from the time I was diagnosed with hepatitis C, and it continues to be an essential component of my good health today. My initial diagnosis meant routine blood work to monitor my liver function tests. As my disease progressed, though, my risk for liver cancer did too, so new testing was introduced. I went from having ultrasounds every 6 months to MRIs every 3 months until I received the transplant. After that, I had CAT scans every 6 months until last year, when I hit the 5-year mark of being cancer-free. Yay! Surveillance will continue in the form of blood tests and annual checkups with my oncologist, but I don't mind that at all. The only reason I'm alive today is because of the diligent surveillance I received. I've known from the start how important it was to monitor my liver, and I've been very careful to follow all of my doctor's recommendations. You can believe that I will continue to do that for the rest of my life.